Hi, welcome back to Your Body. We are still on the East Coast and we are still at Lennox Hill Radiology, and we are going to talk about another topic which we have discussed before, but also another topic that is worth talking about again. So, prostate cancer. Listen up, men. 34,000 men die each year from prostate cancer. And actually, listen up, women who have men in your lives, okay? Because according to the American Cancer Society, 1 in 8 men will be diagnosed with prostate cancer during his lifetime. It is the second most common cancer death in men behind lung. But the thing is, it shouldn't really be the second most common cancer death in men, because when it's detected early, it is highly treatable. So I want to get into a little bit about prostate cancer, men's health, and how we can improve these outcomes. So my guest right now is Dr. John Melnick, who is a board-certified radiologist with special interest in body imaging and with a special focus in oncology and prostate.
Hi.
Right, there's that. So hi, welcome. How are you?
Good.
Good. Thanks for being here. I thought maybe first we could just talk a little bit about your background, like what led you into medicine and radiology and body and prostate and
Sure.
all that stuff.
I'm not sure how far back you want me to go.
I mean, we could go as far back as you want.
So I'm a sculptor outside of
Really?
medicine. And
That's so cool.
I like the 3D nature of that art form.
Yeah.
I found medicine to be just a great platform in terms of looking at 3D structures.
Okay.
There's certain beauty in things that work well, and when the body works well, it's a gorgeous scene. And for somebody like me, who I'm pretty good at seeing 3D shapes and seeing how they sort of fit together.
Yeah.
It's very elegant and it's pleasing to the eye.
Right.
When I first had my first interview for radiology training way back when in medical school, the interviewee, I tried to explain that to the interviewer.
Yeah.
And he said, no, radiology is lists of information that you have to remember.
Mm-hmm.
And I said, but I would imagine when you're a radiologist, you look at picture and you see things working the way they're supposed to be working, and it's like looking at a beautiful painting,
Right,
or sculpture that seems to work and fit together. And the person was the interviewer said, no, that's not what radiology is. He must have been a very sad radiologist,
right, or very
or he loved lists.
Yeah, right.
So either
had
he
one
loved
focus.
lists.
Yeah,
I was lucky that radiology turned out to be what I thought it was. And when I do radiology and I look at pictures of healthy body parts, to me, it looks like a beautiful sunset or an eagle swooping on the wind. You can feel the appropriateness of it, and the elegance of it. When and that emotional content brings what would, to me, be a very dry subject to the list person,
right,
who may be listening to me right now. I don't know. And if you like lists, that's great. That's great. That's not who I am, and that's not who I was.
Yeah.
So, as a radiologist during my workday, I sort of ride the emotional stories of the images in front of me. The healthy image, the healthy person makes me feel good and that the world is right.
Yeah.
When I look at disease, or trauma or any kind of derangement in the body, I feel the emotional discord. In fact, I feel the emotional discord before I process what it is that's causing it.
Right.
It's an emotional reaction. It's seeing seeing an unhoused person on the street.
Yeah.
While you're eating a delicious sandwich.
Yeah.
Right?
Right.
The loss of harmony of that scene.
Yeah.
of one having something and another having nothing. Having, well, prostate, you mentioned prostate.
Yeah.
Having a gland be diseased, to me, it looks ugly.
Right.
It looks disharmonious. It makes me feel sad, and that emotional impact actually hits me before I start processing the images.
Interesting. Wow.
And then what's fun about radiology, to use the word fun, is to use the different sets of images that we get. A lot of these examinations use techniques to acquire different planes, as well as look at the tissues in different fashions.
Right.
And what we do as radiologists, we stack those images up in our mind.
Okay.
Sort of like my background in sculpture.
Yeah.
Putting together a sculpture is to see it from the behind as well as the sides. It's a three-dimensional art form. The human body is obviously a three-dimensional structure, presented two-dimensionally on images.
Yeah.
And part of the radiologist's day, my day, is to reconstruct these images. What's been wonderful in the last few years is the advent of AI, which actually...
I was going to ask you about that. Yeah.
Yeah, so AI is really great because it actually accelerates the merging of these multiple images into a 3D construct that is helpful for me, and I'm very, very visually oriented, clearly. But I think it's actually really great for those people, like that interview.
The list maker.
I had the list maker, where I think that maybe some radiologists are list makers.
Yeah.
And I think that it's really interesting. I think that AI helps them see the 3D nature of things.
Right.
And probably facilitates their experience as a radiologist and their diagnostic capacity.
Yeah.
Well.
Yeah. I'm so like blown away about the way you describe it as being such an emotional experience for you. Yeah. It's lovely, actually. Thank you for sharing that. So speaking about prostate, maybe I feel like it would be helpful if you just sort of explained a little bit about the prostate itself, like where it is, who has one, like what it does,
I have one and you don't.
Okay, right?
Most basic. Prostate gland lies between the penis and the bladder.
Okay.
The bladder empties through a small tube that passes through the center of the prostate gland.
Okay.
That gland helps the semen stay alive in a woman after ejaculation. It's a gland that makes substance, helps with the nutritious part of semen. Oh. It has the tubes that bring the semen from the testicles, the sperm from the testicles around, and those tubes enter into the gland. Okay. So it's sort of a confluence. You think of a highway. Right. It's where all those big highways merge. Yeah. And there's a lot of loop-de-loops in it. Right. It's like a little roundabout. There are lots of roundabouts, and in between the roundabouts, instead of having grassy areas, there's little factories making stuff. Okay, gotcha. So it's a gland. It's an industrial roundabout. It's an industrial complex. Right, okay. So unlike the breast, which I think you're talking to my colleagues later about breast, the breast is, when I talk to women about breast and breast cysts, I use the example of when women get cysts, it's like in a cul-de-sac. Okay. If there's some traffic on the local highway, nobody can get out of their cul-de-sac. Right. And they all sort of stack their cars up in the cul-de-sac, and it sort of expands and becomes a cystic structure. So a lot of breast pathology has has disease along tracks. Right. Sort of everything leads towards the nipple. Right. The prostate's interesting because it's, as I said, it's got these loop-de-loops, the different tubes entering into the main tube, the conduit for the urine. So the diseases of the prostate gland are probably more numerous than we know today. We call it prostate cancer. Yeah. But it's probably much more complicated than that.
Oh.
I think that breast cancer, just talking about a woman's gland versus a man's gland, it seems to the main ones that we talk about in terms of cancer.
Yeah.
We found that breast cancer comes in different forms. There are different types of breast cancer.
Right.
And doctors have generated very sophisticated approaches to the different types. Some use a surgical approach, a wider surgical approach, a narrower surgical approach. Some are augmented by various different chemotherapies. Prostate cancer, I think we're in the early phases of understanding it. There are probably different types, such as breast, but we call it all prostate cancer. Makes it very hard from a diagnostic perspective.
Yeah.
This notion of the PSA, is it good, is it not good?
Yeah. I'm going to ask you about that. Yeah.
It's a little bit related to this notion that we don't really understand the disease.
Yeah.
Some prostate cancers don't mount a very high PSA.
Yeah.
Some mount a very high PSA at one point in the disease, and another point they don't.
Yeah. So it can fluctuate, right?
It can fluctuate. So it's sort of, there are interesting components there in terms of how we screen for it.
Yeah.
But just talking about the gland itself, ball.
Yeah.
Say a ball, a nut-sized ball.
Okay.
That lies underneath your bladder.
Okay.
As we get older, some of those cul-de-sacs that we talked about from the gland, they don't have enough housing. They have little housing developments. Little 4 or 5 story houses can become a little bigger.
Okay.
And that's what we call BPH. So BPH are the glandular part getting bigger.
Okay.
And sometimes that walnut-shaped structure can become bigger and become more orange-shaped structure.
Right.
And when it does that, because the tube carrying the urine from the bladder down to the penis goes through it, this development within the gland. I use the word gnarly because again, remember my emotional.
Yeah.
It looks very gnarly to me. Very ugly.
Right. As soon as you said that, I could visualize it.
Feel it, right? It's and it acts like that, and it kind of pushes on that tube, and that's what causes urinary retention.
Okay.
In people who have BPH.
Right. Benign prostate hyperplasia. Oh, okay. Okay.
Hyperplasia. So the idea is that when this happens, the urine can't empty cleanly from the urinary bladder.
Yeah.
It's not a smooth evacuation.
Right.
It can happen to younger people. It can happen to older people.
Right.
It's just luck of the draw. When that happens, there are a bunch of different things that surgeons and urologists who are surgeons can do. Not everything that the urologist is going to do is surgery. There are a lot of non-surgical techniques. There are drugs that can be used to try to shrink the gland. There are ways of killing the cells that are just adjacent to the urethra that goes down through the prostate. There are anchors that you can use to stretch the urethra open. There are lasers that can be used to sort of cut away
right
pieces of the gland.
Yeah.
People even put tiny needles into the gland and pour steam into the gland and cook it. The expression in urology conferences is you can cook it, freeze it, fry it.
And serve it on a bun.
and microwave it, I think. Exactly.
Delicious.
Put it on the bun. So there are many techniques to shrink it down to allow that urine to pass through.
Isn't it normal for a man's prostate to grow through his lifetime? Or
it's normal. It is typical for it to happen. It is normal. Normal's a hard word.
Okay.
Right? Because I think back in, the Middle Ages, 45 was a normal age to die at.
Okay.
So I don't know exactly how you would apply normal to the aging process.
Gotcha.
But it's not surprising to see BPH in older people.
Right.
It is certainly surprising to see BPH in a younger man, a 45-year-old man.
Okay.
that's causing significant compression. But the beginnings of BPH are certainly there in the 30s.
Oh, okay.
You oftentimes see a little proliferation of that glandular tissue.
And is BPH at all connected to prostate cancer, or it's just a completely separate?
So again, yeah, it's think of the nice spaced suburban houses around the cul-de-sac and a family outgrowing that and building an addition and then an addition and an addition. I think that is the best way to think about it. It can cause disease. Urinary retention can be a pretty serious condition. It ultimately can damage the bladder walls, ability to contract. Pressure can be tracked up into the kidneys, and you can damage your kidneys. So it's something that, and of course, quality of life, having to pee frequently because you can't completely empty your bladder. It's certainly a disease, but no, the BPH does not cause cancer. Cancer is caused by genetic mutations. People oftentimes discuss in a very global sense that the mutations are of two different natures. There's not recognizing who your neighbor is and then not holding on to your neighbor. So the cells are supposed to sort of, when they grow and they die, they're supposed to fill up a certain space. And when they keep on growing and they don't realize that they already occupy the amount of space that they should occupy. That's one type of mutation. Another type of mutation is when they forget to hold on to their neighbor. And that's how you get metastases. When they kind of break away and they float through the bloodstream.
That's a great way of explaining it.
It's cancer's scary. The idea of cells acting in a autonomous way and not respecting their environment is disturbing. And it looks disturbing.
It does.
That the sign of cancer with the
the crazy looking
tentacles growing out. On prostate cancer, when it's early, we obviously want to find it early. We hope to see it inside the gland. Far from the edge of the gland. When it's on the edge of the gland and it's a little bit progressed, it can grow through the wall of the prostate gland and it can form sort of a spiculation, a tentacle, so to say, as it grows into the tissue, the fat around the gland. And that's ugly. Disturbing and it's
like alien.
It's what the patient doesn't want to hear. It makes me feel bad, but as a doctor, right? It's an honor and a privilege to be able to provide this information for patients. It's the worst thing you can tell a patient, that the cancer has broken out of the gland. It makes the radiation field bigger. It brings possibilities of metastases, which may require radiation to include the entire pelvis. And of course, if it's a distant metastasis, you might talk about a chemical treatment as well. So it's pretty dramatic to see that. It's pretty horrible. It's almost it's a good place to talk about the screening program here at LHR.
I would like to talk about that. I did want to go back to PSA really quickly before we jump in that, because we talked about that there are some limitations with that. Like sometimes it's low, sometimes it's high, and that's not always indicative of disease, right? But it is still recommended, right, as the first line for men.
It's a really interesting question. In the popular, well, actually, in medicine has debated the PSA for years now. I started working with prostate cancer back in 2003 when I was doing my early training, and I was lucky to work with some of the great scientists at that time. They were actually using iron oxides which get absorbed by lymph nodes. And it was a way of trying to determine what lymph nodes had metastases and which didn't. And so I was involved in those early studies.
Mm-hmm.
The ability at that time for radiologists to determine the presence of early cancer of prostate gland was not nearly as developed as this today. We guessed and we thought things,
Mm-hmm.
but the scoring system that we currently use called PIRADS had not yet been developed, and a lot of the technologies that we use haven't been developed.
Yeah.
At that time, a prostate MRI took maybe 40 minutes.
Oh, wow.
Today, a prostate MRI is taking, well, for our screening program, without contrast, it's about 8 minutes.
Yeah, wow.
So the PSA concept, I think, is wonderful.
Mm-hmm.
It's a quick blood test that looks to see if the prostate gland is producing too much of this protein that sits on the cell membranes.
Okay.
There are many things that can cause an elevated PSA that aren't cancer.
Yeah.
And there are certainly cancers that grow in the prostate gland that don't mount a large PSA.
Mm-hmm.
So I can't say that it's a great early screening or first screening.
Yeah.
I think that, well, I've come to believe with today's technology that it should be coupled with a prostate MRI, and the super, low cost and ease of access that RadNet's created in terms of their screening program, I think is an amazing adjunct to its utilization.
Mm-hmm.
If you used a PSA, if you acquired a PSA,
mm-hmm.
and your patient had a very low PSA, that's nice. That's good.
Yeah.
And it probably means you're okay.
Right.
I still think you should get a prostate MRI to get a baseline and to make sure that those cancers that do have low PSA aren't developing.
Right.
If you have a high PSA, it could be that you have a little bit of inflammation in your prostate gland.
Mm-hmm.
It doesn't mean that you have cancer, so a prostate MRI is pretty nice at that point.
Yeah.
To see why your PSA is high.
Yeah.
That I find that situation requires a diagnostic prostate MRI, which is a contrast-enhanced study. Because what's nice about the contrast is that it can explain why the PSA is high when I don't see cancer.
Oh, okay.
It's an important distinction.
Yeah.
When you talk about screening versus diagnostic,
mm-hmm.
diagnostic is used when you think there might be a problem.
Yeah.
Well, what I love to be able to say to a urologist
mm-hmm.
is, I don't see cancer, but I do see inflammation.
Right.
And that might be why your patient has an elevated PSA.
Mm-hmm.
What we know is none of these exams are perfect.
Yeah.
And if I tell somebody I don't see prostate cancer on the prostate MRI, they may still have cancer.
Mm-hmm.
The literature suggests 15% of cancers aren't seen on prostate MRI. Even when I know somebody has had prostate cancer, and I look back on studies,
mm-hmm.
sometimes I see nothing to correlate with where the urologist tells me that they found cancer.
Huh.
So some of these cancers are occult
mm-hmm.
on MRI.
Yeah.
The other problem is, of course, the indeterminate finding.
Uh-huh. Yeah.
So you can't call every little bump a cancer or potential cancer and ask to biopsy it.
Yeah.
These exams need to be read carefully.
Mm-hmm.
As the AI develops, the AI acts as a second set of eyes to guide us to sort of ignore some bumps and to accentuate other bumps.
Right.
And that's a process that is getting better over time.
Mm-hmm.
And that's one of the important aspects of using a study that has become a diagnostic gold standard,
right,
for a lot of urologists.
Yeah.
And sort of moving it into the screening realm.
Okay.
Because of those false positives.
Right.
The AI is developing to the point where eventually we will be able to augment the radiologist's interpretation and ignore certain findings.
Yeah.
And that's a very important thing as the AI develops.
Yeah. So it's similar to how it's being used in breast.
That's correct.
Yeah. Yeah.
That's correct.
Okay. So let's segue into the screening program, Enhanced Prostate Screening, or EPS, as some of us like to call it. So that is a screening program that's here at Lenox Hill. It's RadNet. Let's talk about that, because that is just, using the MRI as screening with or without the PSA, right? Is that right?
So the idea is to provide a look inside people's bodies who don't have access to maybe the most careful physicians,
Mm-hmm.
who are a little bit anxious about having a big conversation about it, or who would have some degree of suspicion,
Mm-hmm.
but don't want to go the full distance in terms of seeing the urologist,
Okay.
getting contrast.
Mm-hmm.
The PSA for somebody for the screening study
Mm-hmm.
should probably be low.
Right.
Once you have an elevated PSA, I think that you deserve to get a diagnostic prostate MRI for the reasons I gave before.
Yeah.
I want to be able to tell you, hey, I don't see prostate cancer, but I see prostatitis,
Yeah.
a lot of inflammation, maybe a little bit of antibiotics will take it down if it's clinically warranted.
Mm-hmm.
The moment I say clinically warranted, I'm talking to your urologist.
Yeah.
Or somebody who's feels comfortable taking care of your genital type problems.
What's the cutoff? The PSA cutoff?
Well, there's no cutoff. For the screening study, we picked a very high cutoff.
Okay.
We picked 12.
Oh, wow.
That's a very high cutoff, and we did that because we didn't want to exclude. We didn't want people to be excluded from this tool.
Okay.
Who could benefit by it?
Yeah.
The non-contrast portion of the exam is very good at finding cancer.
Okay.
The
Wow.
contrast can upgrade findings and make our findings that are indeterminate more suspicious.
Okay.
And they can tell us if there's prostatitis, which could be a cause for an elevated PSA.
Right.
But on the screening study, if you were to have an indeterminate finding, you're going to chase that down.
Right.
So that's why I felt comfortable offering this study without the contrast. Because pretty much unless you have a normal study, you're going to think that you have to take a closer look.
Okay.
So you're going to go to your urologist at that point. You're going to have a full workup. Maybe you'll repeat the prostate MRI and get a diagnostic prostate MRI at that point.
Yeah.
But the non-contrast portion of the exam, which is what we offer in the screening study, is very good at finding cancer.
Interesting.
And it's probably, it's to me, it's great as an augmentation tool with PSA, as a screening exam, because it helps with this notion of acceleration. Have you heard the term for?
No.
So PSA there are two ways of looking at PSA. There's an absolute score and there's an acceleration. In other words, you have 2 time points.
Okay.
Think of a graph. You have 2 time points on the graph. If the PSA between time point 1 and time point 2 is flat, that's a good sign that you don't have anything developing in your gland.
Yeah.
If your PSA was very low, 2, and over the year it goes to 4, that's an acceleration. It's growing.
Yeah.
And that acceleration is worrisome from a urological perspective.
Yeah.
And is going to trigger some kind of a workup, in this case, prostate MRI.
Okay.
I like the prostate MRI to accompany that PSA because we can see, in the same way that a PSA score accelerates, we can see lesions accelerate. So if there was a little small ditzel on time point 1 with your PSA at 2, and at PSA 4, it got bigger and fatter, we think we might know what's causing that PSA rise.
Right.
So this notion of a baseline helps us see what change is. Now, for some people who have a very pristine prostate gland, go back to my example of the eagle.
Yeah.
That perfect
Beautiful
prostate gland without a single abnormality in it. That gland is very easy to see cancers in.
Right.
A lot of people have had prostatitis. Prostatitis is usually infectious bacterial infection that can cause scarring in the gland.
Okay.
And once you've had that scarring, the scarring can somewhat hide tumors. Those very small, because this is all about finding them small and finding them early.
Right.
So it can make it can mask and hide and make it difficult to see smaller lesions. The reason why I like to have priors is because if you have a prior, it's easier to see what wasn't there 2 years ago.
Right.
So when we talk about the screening program, what I would hope is that people get this type of exam every few years so that they have a track and you can look back in time and see where things were developing.
Okay. So it's recommended for men to start having screening at age, what is it, 40, 45?
Well, we picked 45.
45. Okay. So would you recommend that men at age 45, regardless, just get a baseline MRI screening?
So the reason why we picked 45 was because the gland, from an imaging perspective, changes fairly consistently at 45. Before 45, the whole gland has a very, well, I'll use the word aggressive. It has the features of prostate cancer, which is very interesting. Yeah.
Really?
The young man's prostate gland sort of lights up in a way that we would expect a tumor to light up.
Really?
So it's the MRI is not very valuable before 45 because since the whole thing is lighting up in the same way as a tumor, it can be sort of challenging to find a tumor.
Yeah.
Also, prostate cancer is pretty rare in a young man.
Yeah.
After 45, the prostate gland starts to evolve into what it looks like for the rest of the person's life.
Okay.
With the exception of the scarring that can occur with episodes of prostatitis, which we probably all have. It's very rare to see a gland in an older gentleman doesn't have some scarring in it.
Okay.
So that's where we got the age 45 from.
Okay.
Prostate cancer becomes much more common as you get older. So from a yield perspective, you could be older before you get it.
Yeah.
And if you're coming for a detection, then yes, you are more likely to find it if you are older.
Right.
However, we don't want to find it when it's growing out, when that spiculation is going out. We want to find it when it's small and inside.
Yeah.
We want to find developing.
Right.
So 45.
Right.
Mammographers use 40. And what's interesting for them is it's actually the same reason that we picked 45 for this study.
Yeah.
Because the breast changes. The breast of a young woman is quite dense.
Yeah.
It's hard to see.
Yeah.
Even developing cancers in a young woman's dense breast.
Right.
And that's why they oftentimes turn to ultrasound.
Right. Right.
In the same way, the gland changes in a man and gains its more mature form. I'll call that mature because I'm over 45.
It is very mature.
It gains its more mature form after 45.
Right.
And that's why when you're looking at it, it has this appearance without the cancer, a little scarring.
Yeah.
This is just like a little bit of gray in my hair. It's just sort of the beauty of
it makes
of
it
aging.
distinguished.
Distinguished. The cancer is the attack and
right.
And that's what jumps out. And moving on to the AI side of the EPS, the AI is compiling all of these images,
right,
creating a map, which lights up areas that the computer thinks is suspicious.
Right.
And what I do, this as a radiologist today, is I correlate those areas that it lights up as worrisome with my images, and I act as the last. I'm the buck stops with me.
Right.
And I take what the AI suggests, and I have to come to a conclusion as to whether or not this is concerning.
Yeah. Yeah.
And pass the patient either back to their internist to say, hey, everything looks great, or
Right.
there might be a problem here. You should see a urologist.
Yeah. Yeah. That's really cool. So do you see like this kind of screening becoming like what mammography is to breast?
I would hope so.
Yeah. Because why wouldn't it be? I mean, it's prostate cancer is so prevalent aside from PSA, which is not that reliable. There is no way to screen for men, right? Except
when we started this study about a year ago, like this program, we started with a small study because we were working on the protocol.
Yeah.
We initially wanted men to do an enema before, because the less, the less, well, prostate gland sits in front of the rectum. The rectum is a vault that holds stool and air, and if it moves, it can bang into the prostate gland.
Oh, okay.
And MRI, the images of MRI degrade with motion artifact. Right. So that knocking causes the images to not be have as high diagnostic yield.
Right. You need it to be still.
I need it to be still.
Yeah.
Like an old timey camera, black cloak, and
hold your breath.
Right.
Freeze. Okay.
So we originally started with the idea of taking enema. On our diagnostic prostate MRIs, we have people take an enema.
Yeah.
But what we realized in doing family and friends was people didn't want to do it.
Yeah.
My friend said, really, I have to do that? I don't really want to do your study. So we wondered what it would be like not to do it.
Yeah.
The other aspect of the enema is that we started it a long time ago.
Yeah.
When the machines were slower.
Right.
So in today's world, with your iPhone, you can take a gorgeous picture moving it.
Yeah.
And motion's not as important.
Right.
When your images are acquired within 8 minutes versus 30 minutes, motion is less important.
Yeah.
So we wondered, what could we do to get people to come in to get the study?
Yeah.
Remove roadblocks.
Yeah.
We wanted to remove as many roadblocks as possible. Now, Gas X is a little tablet that you can buy in a grocery store that decreases that gas.
Okay.
That can cause some knocking. We have people take a couple of tablets of Gas X right before the exam.
Okay.
Actually has significant impact.
Oh.
Another thing that we ask people to do, which isn't a big deal, is not eat dairy kind of stuff.
Right.
The day before.
Yeah.
Again, just a little bit more, a way of decreasing that gas.
Yeah. Yeah.
If you are chronically constipated, and I guess if somebody's listening to this podcast and is thinking about doing our study, if you are a chronically constipated person, you should do the enema.
Right. Yeah.
Because these mitigations that we're talking about are for sort of your routine person.
Yeah.
And it works. It works most of the time
to
take that motion out. If you're constipated, do the enema. Yeah. And I'm saying that to you. if you're out there and you're going to get air set. So for this study, I had a party at my house and I had all friends and family over. It was a Chinese New Year party.
Okay.
Last year. And I wanted to sign people up because I wanted to see if this would work.
Right.
And if people would be willing to do it. And it was easy and I needed some feedback.
Yeah.
I probably got about 15 of my friends to do it.
That's a pretty good number.
That's a pretty good number.
Yeah.
One of them had cancer.
Stop.
He was 45 years old. He was just about to turn 46. And the joke was he just made my cutoff. And sitting there eating Chinese dumplings in one hand and, some ginger ale in the other hand saying, hey, you got to do it. This is a great thing. I'm just playing around with my protocol right now.
Right.
Just jump on. We have magnets all over New York City. Melnick radiology is on every street corner. Yeah. 80, 85 centers. Yeah. We're all over the place. Yeah. So it's easy to come get it. we do it on these magnets called 3T magnets, which are the high field magnets.
Okay.
So easy to do.
Mm-hmm.
And I'm saying this to the person while we're stuffing my wife's boiling up dumplings, and there was a rah moment where people were like, "Okay, come on, let's help John out. Let's go sign up for his silly study."
Right. Oh.
Which wasn't too silly.
No.
A couple of months later, when I called him, and I said, "Hey, sorry, buddy, but you actually have a lesion," and it was perfect.
Mm-hmm.
It was a perfect situation. It was small tumor.
Yeah.
In the middle of his gland,
mm-hmm.
not close to the margin, no spiculations, no lymph nodes, no metastases. He had a treatment that required no surgery. He laid on a table for every other day for a week and a half.
Oh, wow.
Getting radiation.
It's just radiation.
And he's done.
That's amazing. And he had a PSA or anything prior to that? Or he just went in for
No, but
to be your guinea pig?
What's interesting is his father died of prostate cancer.
Okay.
So when I said it to him,
mm-hmm.
he didn't tell me that at the time. He told me when I told him.
Yeah.
And he said, gulp.
Uh-huh. Yeah. Yeah. So I am actually having my husband do this in a couple weeks as we are rolling it out in California. His father died of prostate cancer. He spent nearly 20 years fighting aggressive prostate cancer that metastasized to his bones, and he was really sick, tried a lot of different things, and he finally died from it also. So I'm having my husband do it.
I think it's great.
Yeah.
I've certainly had my family members do it.
Mm-hmm.
I've done it.
Yeah.
I can't see of a reason not to do it.
Yeah.
The price is so low.
Yeah. Because it is out of pocket at this point.
It is out of pocket.
Mm-hmm.
But it's, if it showed you a disease that was untreatable,
mm-hmm.
if it showed you a disease that was treatable but the treatment was terrible, and you didn't want to think about it,
mm-hmm.
like it's some things are so horrible that while they're possible, it's better just to pretend that headache you have is just a headache, not something terrible.
Yeah.
This isn't like that.
Right.
This disease starts small and it stays small for a really long time, usually.
Yeah.
Sometimes they can go fast.
Right.
And that's why my recommendation isn't to get it at 50 and then 60 and then 70 and 80. I would suggest a higher frequency.
Right. Not that slow.
Right.
Yeah.
But it's just something that can be looked at. The biopsy is interesting.
Oh, yeah.
The biopsy.
I was actually going to ask you that. Uh-huh.
Yeah. So when I trained back in 2000,
mm-hmm.
the biopsy was going through the rectum
mm-hmm.
with ultrasound guidance. In around, 2009 or so, 2010, I was doing MRI guided biopsies
mm-hmm.
where I was targeting lesions with an MRI machine, and
mm-hmm.
the patient laid in the MRI machine, and I passed the needle through the rectum into tumors.
Okay.
I actually diagnosed both my father and my uncle with prostate cancer in my MRI machine.
Wow.
And that was about 2000. Well, they were later on, but I started about 2010.
Okay.
The technology is amazing.
Yeah.
And what was developed after that was to fuse the MRI machine images
mm-hmm.
that I was able to paint a target on and fuse my target and the MRI onto an ultrasound machine.
Mm-hmm.
And so ultrasound is much more comfortable to get a biopsy on than my MRI table.
Got it.
And so what happened was patients were able to see the urologist. Urologist was able to do it through the rectum
mm-hmm.
using ultrasound,
mm-hmm.
but with the guidance of MRI. And that was amazing.
Yeah. Yeah.
And now what they do, which is more amazing, and I really think turns the corner on this, is they also do it under ultrasound. They also do it with fusion. But now they go through the perineum, which is the area between the anus and the scrotum.
Okay.
And they go through that area. And what's so special about this is that it takes away the risk of infection and bleeding.
Oh.
The rectum is a dirty place.
Yeah.
And when you put a needle through the rectum, the chance that you give the person an infection after finding out they have prostate cancer is pretty significant.
Yeah. Oh, wow.
When you go through skin that you can sterilize,
right,
you decrease that infection rate dramatically.
Oh, wow.
When you go through the rectum has large veins in the sides. They're called hemorrhoidal veins.
Yeah.
And those veins, when you put a needle in, you can slice one of them open, cause bleeding. You can't control the bleeding in the rectum.
Yeah.
Through the perineum, you can, again, avoid or dramatically decrease the risk of bleeding.
Yeah. Yeah.
So what you now start to talk about is a disease that is a slow-growing disease. Is the screening has become very comfortable.
Yeah.
We've taken down the roadblocks to entry.
Right.
The identification, the tissue identification now becomes risk-free.
Right. Right.
Still a little bit of risk, but pretty risk-free.
Yeah.
And the treatment options are so varied.
Yeah.
You can do it with, as my friend did.
Yeah.
Where you can have radiation. If you want your whole gland out, you're in and out of the hospital.
Yeah. And there's also that ablation now.
There's
pulsa. Yeah. There's so much. Yeah.
Fry it.
Yeah.
Steam it.
Put it on a bun.
There's so many different things to do. But going back to that analogy of the headache and the brain tumor.
Yeah.
Like we all get headaches.
Yeah.
We don't think it's a brain tumor. We take aspirin. For prostate cancer, why should it be in our community as it was for your husband's father?
Right.
A debilitating disease. Why should we have that? It seems that, my job at this point is to tell as many people as I can, as many forums, as many luncheons with urologists and internists. It's just the people who know are using it. Yeah. And I just want more people to know.
Yeah.
Because it is something that we really should be treating more aggressively today.
Yeah. Yeah. I agree. There's no reason why the death rate should be so high for something that is so treatable. I completely agree. Well, hopefully we can get the word out more about it. And hopefully men will actually adhere to, doing it. Because I guess that's the other piece of the puzzle. Is men aren't very good at...
you know what's interesting?
Yeah.
Once you do it once, you walk out, you feel so good.
Yeah.
You're like, I'm normal.
Right. You're like, I took care of myself.
It's kind of scary walking in.
Out. Yeah. Right. It's no big deal. You did it. You're good. Healthy. Feel good taking care of yourself. Just do it. This was a great conversation. It was really good. Really informative. Thank you so much. It was really nice to talk to you.
Have a good day.